Thank you so much, Annette, and thank you to Dr. Rosapon for starting off this debate. As the first opposition speaker, it will be my duty to tell you and open the argument to say that Doxy PEP as post-exposure prophylaxis for STIs should not be the standard of care for people living with HIV and for those who are seeking HIV PrEP. Now, my central argument and the argument for my team that Dr. Kao Tui will be following up on is that it is not yet time for Doxy PEP to be considered standard of care. And the reason for this is that the words standard for care are central to what we are here to argue today. Standard of care means that the intervention that we are using, the treatment, the prevention, anything that we are going to implement in our clinics is the same kind of care that a prudent, a reasonable person with the same amount of information would do under the same circumstances. Now, that's the legal definition. For most of us in the room who are clinicians, we also accept standard of care to mean that this should be what we are doing for most, if not all our patients, except if there are certain specific contraindications. So what I am here to argue for you today is that Doxy PEP has not yet met this standard. It is not yet ready for prime time, because if we are to say that Doxy PEP was to be standard of care, if you did not prescribe Doxy PEP for your patient, you would have failed to meet this standard, and this can carry some significant consequences for you as a prescriber or you as a clinician. So I say, how confident are you? Are you willing to stake your practicing certificate on not giving patients Doxy PEP in your prevention clinic or STI clinic? And I say, I'm not ready yet, and I hope to convince you similarly. Now, the opposition team says that in order for Doxy PEP to be considered standard of care, you need to answer 5 questions. Number 1, you need to be sure that Doxy PEP is effective. Number 2, it's safe for individual patients. Number 3, it's safe for communities and populations. Number 4, it is the right thing to do now. And number 5, it is an urgent priority. And I think through Dr. Kao Tui and I will show you that it fails on all 5 of these counts. So the first argument, Dr. Rosapon did me a great favor by summarizing all of the 3 randomized control trials on her table. And you realize that one column in her table that was not there was the time of follow-up for each of these trials. Now, all of these trials are based on data that is roughly around a year of follow-up. Is 1 year of follow-up adequate for us to include Doxy PEP in our guidelines? Is it adequate for us to say that this is standard for care, I say, not really. I'd like to wait for a little while more and see whether the results that have been so promising, or allegedly so promising up to this point, actually follow through beyond the first 48 weeks of follow-up. And the second question around effectiveness is, all of the studies have shown it's not great for gonorrhea. And Dr. Rosapon has said that gonorrhea is a real problem amongst MSM. And the guideline, all of the trials have only really recruited men or people who are assigned male at birth. If it's not great for a group, but the problem is really a big problem, is it enough for us to put it as standard of care? I don't think so. Number 2, is Doxy PEP safe for individuals? And I accept that this is probably my weakest argument. Doxycycline is used fairly widely. It's safe, as Dr. Rosapon says, but is it harmless? It's not. There are side effects that can occur, and while they occurred in very small numbers in those trials, remember, those trials only recruited, hundreds or so of patients. When we make something standard of care, the number of people who are going to be taking a doxycycline every day is going to expand, is going to go through the roof. The number of severe side effects that we will start to see in our patients will go up as well. And if we think that it's not that useful, not that effective, but we're giving it to so many people and causing so many potentially serious side effects, including things like benign intracranial hypertension, changes in the host microbiome, etc., etc. Is it worth that risk? Now, we've already started seeing this problem with HIV PrEP, where HIV PrEP is taken in the wild quite commonly in Singapore, for example, where people don't see a doctor, they hear from the news that this is useful. Doxycycline is even easier to buy than Truvada, right? And they start taking it on their own. The potential risks of these side effects occurring in people who are not seeing their doctors is not worth the risk of making Doxy PEP standard of care. And that is what is likely to happen if we are not careful. Now, Dr. Kao Tui's entire speech will be focusing around the risk towards communities, or otherwise known as antimicrobial resistance. So I'm not going to spend too much time on this, but suffice to say, doxycycline can not only drive increased resistance in exactly those STIs that we are trying to prevent, it can even cause resistance in other bacteria. And I'm here to say that most of us doctors, our clinicians in the room, and even scientists in the room, we've been hearing so much about these three letters, AMR, over the last 10 years or so. AMR is the bringer of doomsday. AMR, people are not going to have any antibiotics to use anymore. And here we are, on the other hand, saying, yes, use more doxycycline, generate more resistance. I think it's going to be really difficult for us to balance these two messages. It's going to be confusing for patients, confusing for doctors. We are not yet ready for Doxy PEP. Number 4, is Doxy PEP the right thing to do right now? All of the guidelines, the US guidelines, the German guidelines, the European guidelines that have recommended Doxy PEP say that it should only be used for gay and bisexual and other MSM. But we already know with the example of PrEP, that even in places, or even with something like PrEP, where we don't limit it to one group, there are people who aren't accessing something that's really useful for them because of the way in which it's implemented. And I say that if we implement something like Doxy PEP, where we only focus on one group and ignore other people who are at risk of STIs, then this kind of inequality is going to be further engendered, and we simply cannot have that. My last point is that, is Doxy PEP urgently needed right now? I say to you, as Dr. Rosapon said, the problem with STIs right now is that potentially we are not screening enough, we're not testing enough, and we're not putting enough education out there. Implementing Doxy PEP will lead to 2.58 million doses of doxycycline being given in the US alone. Whereas if we were just to screen and treat them, we only need to use 62,000 doses of doxycycline. The difference is wild, the cost is going to be incredible, the side effects and the potential harms are too great. I put it to you that doxycycline as post-exposure prophylaxis for STIs is not what's needed. I'm not confident enough, my insurance is not strong enough for me to propose this with a good conscience, and these are the references from which I drew my arguments today. Thank you very much.